Another debilitating disease we frequently come across is psoriasis. And psoriasis in pediatric population means more physical discomfort, emotional distress, and social stigma. For understanding and addressing the unique challenges of pediatric psoriasis, may I please call upon stage a great human being, a superb mentor to most of us, and a very strong advocate of empathetic clinical care and medical education. He is an amazing supervisor, examiner, convener, author, ex-head of Department of Dermatology, Pharma Medical University and Jinnah Hospital. Ladies and gentlemen, please put your hands together for Professor Tariq Rasheed, sir.
Bismillahirrahmanirrahim. First of all, I highly appreciate the efforts of Professor Zahida Rani. Oh, Professor Faria sir! Faria uधर देख रहे थे। ज़्यादा सर। Professor Harun Nabi. For organizing this highly useful academic event. And I am thankful to you all for giving me this opportunity for this talk. My main focus of this talk will be on management of pediatric psoriasis. The psoriasis in children affects about 1% of children population. However, most of the studies report that the psoriasis is underdiagnosed and underreported all over the world, and similarly is the case in Pakistan. And about 1/3 cases of psoriasis start in childhood. It means a substantial portion of psoriasis is seen in children. However, what we see is that childhood psoriasis differs in many aspects clinically from adulthood psoriasis. And I think this is the main reason that these cases are not properly diagnosed or misdiagnosed. One example is napkin psoriasis. Napkin psoriasis is usually diagnosed as irritant contact dermatitis, seborrheic dermatitis, or zinc deficiency. But the reason is why it is diagnosed as dermatitis rather than psoriasis is that the lesions here are not scaly. They are moist due to humidity, due to occlusion. So these are not presenting typical features of scaly plaques as you see in adults. So this is the reason this is misdiagnosed. But we can differentiate it from eczema because the margins would be well defined. And these would be erythematous, and then these would not be responding adequately to topical steroids, and these would be recalcitrant. So if a child with recalcitrant chronic diaper eczema presents to you, can we always think, can it be psoriasis? Then another type is which poses problem clinically is guttate psoriasis, because a child presents to you, to us, with acute eruption, generalized acute eruption, small, few millimeter papules, but scales would be less or deficient. So again it mimics like lichen planus, misdiagnosed as secondary stage of syphilis, pityriasis rosea and so others. So again this may be misdiagnosed, but history of, in such cases you must take history of streptococcal sore throat, because purulent tonsillitis, a recurrent streptococcal infection is usually the treatment factor of such cases. The plaque psoriasis is the commonest type of psoriasis which is seen in children, as multiple studies have reported this. That is more common as compared to guttate and napkin psoriasis, but these are the different difficult psoriasis to diagnose. Then lesions over the face and over the scalp are more commonly seen as compared to adult psoriasis in children. And interestingly, many of us might have seen, you might have seen, as I have seen, the patient may present with only one or two or few lesions of psoriasis over the face only, or over the scalp only. And then it becomes difficult to differentiate it. Like over the scalp, it is usually misdiagnosed as seborrheic eczema, atopic eczema, and over the face it may mimic tinea or eczema. So again it becomes a problem. Then scalp psoriasis is also more common as compared to adults, and it mimics other dermatoses. Innate findings in childhood psoriasis are same as adulthood, like pitting, onycholysis, and so on. And these studies have reported that these may start before, during, or after the onset of skin lesions, as we see in adults. Then in childhood psoriasis, female predominance is seen, while in adulthood psoriasis we know that males predominate as compared to females. So girls are more predisposed, prevalence-wise, to childhood psoriasis as compared to adults. And family history is more common as compared to adults in patients in children with psoriasis. Guttate psoriasis and follicular psoriasis are more common as compared to adults, and leptin psoriasis in infants is common but uncommon or rarely seen in adults. Severe forms like erythroderma and pustular psoriasis are rare. So, childhood psoriasis, mostly this is mild. This is the good news. Because the rare and severe cases like erythrodermic psoriasis, pustular psoriasis are less in children as compared to plaque type, guttate type, napkin psoriasis, or isolated lesions of the scalp or over the face. But diagnostic problem is an issue for the clinicians for us. An important thing which becomes makes it more perplexed for us to diagnose is because the lesions are less indurated. These are thinner as compared to plaques of adults. This is important. So, and the scales are less scaly plaques, and pruritus is more common in children as compared to pruritus in adults. Now, location is the same as adults, but the facial lesions and scalp lesions are more commonly seen as we have discussed. A good news is that its prognosis is better than adults because more of the cases are benign, mild. And another good news is that there are more chances of complete remission as compared to in adults. Various studies have reported this. The infections, that is streptococcal infections, stress and trauma, again are the precipitating factors. Even sunburn has been reported in children as a factor of psoriasis of the face. And trauma leads to communalization and lesions of different parts of the body. But drugs, as we see in adults, are less common as a cause of precipitating factor of psoriasis. Now, still now, we are mostly talking of comorbidities in adult psoriasis, but there was a concept, at least for me, that probably these are less common in children. Although these are less common, but these guidelines say that we must evaluate these. Psoriatic arthritis is seen in 1 to 11% of children with psoriasis. Now, how this psoriatic arthritis will present in children, that we should ask the parents, does your child feels pain in the morning in the hands? Because this pain is more at rest and decreases as with the movement. So morning stiffness again is an important feature of childhood psoriatic arthritis. Similarly, swelling of digits, swelling of joints and tenderness can be seen. And then psoriatic arthritis, children with psoriatic arthritis have been reported to have an incidence, high incidence of uveitis. And how the patient will present? The mother may say that this child eyes become red, the child feels pain, blurring of vision and photophobia, difficulty in seeing and problem closing the eyes while going to sunlight. Then psychiatric problems is very, very important in the children right from the early age, especially the anxiety, depression, stigmatization while going to schools. The peers would make bully of the child. And no, this depression and anxiety is not seen only in the children, but in the parents also. So we must take care both of children and their parents. Then obesity, diabetes, hyperlipidemia, and inflammatory bowel diseases all have been associated with different percentages in children with psoriasis. Now, how will we monitor obesity? Obesity should be screening should start right from the 2 years of age according to BMI. Dyslipidemia by fasting lipid profile, especially in children with cardiovascular risk factors. Type 2 diabetes after every 3 years, and hypertension starting at the age of 3 years. So these are important concepts that we must not only treat the skin lesions, but holistic approach is needed, holistic multidisciplinary approach is needed, and refer the patients to the appropriate specialist. The non-alcoholic fatty liver diseases should start by assessing ALT at the age of 9 years. And mood changes, screen yearly for anxiety and depression regardless of age. So this is important. We must be aware of different tools to assess psychiatric health of the child and start its evaluation right in the first year of the when the child first presents with psoriasis. Now, what are the challenges we feel as a clinicians in the management of psoriasis, children with psoriasis? Major challenges. First, there are limited number of medications, both biologics and non-biologics, which are approved by the US FDA and European Medical Agency. This is a big problem. While there are many drugs which are approved by FDA and EMA for the adults. Number two, there is more discomfort due to topical application of medications. Now the children really feel problem in the taste of oral medications and aversion to injections. And as clinicians, it has been found that they are more hesitant to change between biologic regimens. For example, they first started with etanercept and it is ineffective. They want to change it to adalimumab, but there is hesitancy. And then there is also hesitancy in combining biologics with others like methotrexate or acetate. There is concern to minimize treatment adverse effects due to longer duration of treatment, because childhood psoriasis need long-term management. Maybe it continues in adulthood. So both the doctors and the parents are concerned with the long-term cumulative risk of both topical and systemic therapies. Therefore, we have to use the rotational therapies, sequential therapies, combination therapies, and so on in the management of childhood psoriasis. Now, topical therapies. First, I will talk about those therapies which are FDA approved. And this is roflumilast 0.3% cream. This is phosphodiesterase 4 inhibitor. This has been approved for children above 12 years of age. Calcipotrione foam, calcipotrione and betamethasone foam and ointment, and then halobetasol propionate foam. These are the only drugs which are approved topically by FDA. Roflumilast is approved above 6 years. Calcipotriene alone foam is approved above 4 years of age, both for scalp and body. But important thing is application to more than 30% body surface area is not recommended because of increased chances of absorption and hypercalcemia. So we must be careful while giving vitamin D analogs over large surface areas. While calcipetrol and betamethasone suspension about 12 years and halobetasol steroid form a lotion about 12 years of age. And its maximum amount is also mentioned. Now, these were the labeled drugs, approved drugs. But again, the problem is, others that we are using till now are not approved till now. These are off-label medications, like topical corticosteroids. And we know that in topical corticosteroids, in a child, because there is larger body surface area as compared to weight, there are increased chances of absorption, especially in psoriasis. The barrier function is disturbed, so it would lead not only to skin-related side effects, but adrenal suppression will also be there. Therefore, it is recommended that only mild steroids should be used only for a shorter period of time. Now, topical calcineurin inhibitors, which are approved for atopic eczema, are also off-label used in psoriasis, especially for lesions over face, for lesions over anogenital region, and for flexural psoriasis. Although this is less effective and it takes time, but gradually it affects peers. And then initially there is irritation and burning due to this. So this is a problem in the use of calcineurin inhibitors. Topical tazarotene is approved for adult psoriasis but not for children, but it has been used for nail psoriasis in children and for localized palmoplantar lesions in children also. Then topical coal tar and topical anthraline, again these are off-label use, but their use is very limited because of their irritation potentials, burning, smell, and difficulty to use by the children. Salicylic acid is only used for a very short time of palms and soles in children in a very 1 to 2% concentration. Now, as I already discussed, combination therapies, steroids with vitamin D, or rotational therapies. Rotational therapy means that we start topical therapy with steroids with vitamin D, then we rotate it with vitamin D only, then emollients only, then UVB only, so like this. This is meant by rotation therapy. Now, phototherapy. Now, it can be offered to children as long as they are able to stand in phototherapy chamber alone and can follow instructions. So mostly use narrowband UVB for 6 years or older, preferably adolescents, that is 11 to 17 years of age. It's well tolerated with minimal adverse effects. However, it's prolonged use because if we start its use in children, then we know that it has to be repeated off and on. So long-term toxicity leading to premature aging, induction of malignancies risk is there. Its number of exposures should not be more than 35 at a stretch and no more than few cycles, 2 cycles per 2 to 3 years. Photochemotherapy is contraindicated in children younger than 12 years of age. Excimer laser may be efficacious, but supporting evidence for its use in children is limited and treatment is quite painful. Systemic therapy. All systemic non-biologics are off-label in pediatric psoriasis. This is a major problem in the use of these drugs in children. And these are the drugs like methotrexate, acitretin, and cyclosporine that we are using. It's used safely in children 2 to 16 years of age for plaque, pustular, erythrodermic, and psoriatic arthritis. Cyclosporine use is reserved for severe forms of psoriasis. Its dose range is 2 to 5 milligram per kg per day administered in 2 divided doses. So, cyclosporin is a good drug even in, as we were discussing, atopic eczema. In acute flare, my personal experience is it's even better than systemic steroids if I use it in acute flares of children with severe atopic eczema. Acetating is a non-immunosuppressive, safe and effective therapy in children as young as 6 weeks of age. So it can be used in very early age, and its dose range is 0.1 to 1 milligram per kg per day for all pediatric age groups. So it's a good drug which can be used in infants and children safely. Now, biologic therapies which are approved are the 6: etanercept, adalimumab, secukinumab, ustekinumab, and ispikinumab. Now, of these, etanercept and secukinumab, both are available in Pakistan. So I think these two, we must be skillfully using these drugs in the management of moderate to severe psoriasis in children. Like etanercept is used, approved above 4 years of age, and secukinumab above 6 years of age. And all these are drugs are used subcutaneously. Now, proactive therapy has been, multiple studies have confirmed its usefulness in the management of pediatric psoriasis. And what is this? Professor Levine has also explained, a long-term management of clinically intact skin, not diseased skin, of clinically intact skin in previously disease-affected areas with minimal dose of drugs. Like psoriasis is settled, no lesions. Skin is normal, but what treatment should be given? This is proactive therapy. And there are various ways to administer this proactive therapy. It's implemented to maintain remission and decrease exacerbation. This is its aim. This is used not only in psoriasis and atopic eczema, but also vitiligo. And this has proven efficacy in so many studies. Because subclinical inflammation that contributes to relapse has been identified in biopsy of seemingly intact skin of patient with psoriasis. Here is the concept of memory T cells which remain over there and they become active due to triggering factors and lead to inflammation and produce the skin lesions. It improves the patient's quality of life. Aims to limit the need of reactive treatment. As Dr. Lambis has explained, reactive when the disease occurs. It's cost-effective and good safety profile with low risk of side effects. Useful in children with mild psoriasis with plaques recur again at the same site, for example, the elbows, over the knees, especially with the face, the anogenital region, the flexural regions. What to do? Gradual withdrawal over several months to prevent relapse. This is the first rule. Never stop any medications abruptly. When the lesions are healing, taper it down. For example, if you are doing it daily, alternate days, then twice in a week, then once or twice in a week. Weekend therapy, topical corticosteroids and vitamin D analogues, just on Saturday, Sundays. Just on Saturday, Sundays. And then only vitamin D analogues on Saturdays and Sundays. The rest of the week apply emollients liberally. Then on-demand therapy is also a part of proactive therapy. Early treatment of first symptom of a flare. First symptom of flare, don't wait, but administer proactive therapy. Now there is a concept of proactive systemic therapy also. Maintenance of remission of psoriasis in children with minimal effective dose. That you have started cyclosporin, for example, or etanercept of a child, to a child with psoriasis, then gradually taper it. As you know, as we all know that when we stop cyclosporin abruptly, there is rebound, even more severe than the initial severity of psoriasis. So even minimal effective dose is given on weekends. Studies have proven that even once or twice weekly use of cyclosporin helps to keep psoriasis in remission in children. Similarly is the case reintroduction during initial phase of relapse. Now there are some topical drugs under trials for pediatric psoriasis. Roflumilast cream is approved, but now they are considering foam, which is easier to apply on the scalp and body. Then topically tapinarof, which is aryl hydrocarbon receptor modulator. Then benvi-timo, again the aryl hydrocarbon receptor modulator. And halobetasol propionate and tazarotene combination. Steroid vitamin D combination is available. This is the steroid plus retinoid combination. Trials are going on. Then systemic drugs under trial for pediatric psoriasis are infliximab. This is approved for psoriasis in adults, but in children this is approved only for Crohn's and ulcerative colitis, and not for psoriasis. So trials are going on this. An important thing, good news is that phase 2 trials have been completed in an oral IL-23 and 17 inhibitor. This is phase 2 trial has completed and showing good results. Significant PASI 75 reduction after 16 weeks. So this is, and it's quite safe. Now apremilast has also shown good results in phase 2 trials in children above 6 years of age, good safety and good efficacy, and dose is according to weight. Like if the weight is less than 50 kg, 20 milligram twice a day. If above 50 kg, it's 30 milligram twice a day. So take home messages. No doubt, management of pediatric psoriasis is challenging because of all the factors we have just discussed. Screening for comorbidities is important, and skillful and early use of topical and systemic therapies can adequately control the disease. And biologics is a ray of hope. Thank you very much.
सर थैंक यू वेरी मच. कोई क्वेश्चन? वैसे तो सर ने इतना डिटेल में समंदर को समंदर ही रहने दिया और मुझे में बंद नहीं किया, तो मेरा ख्याल है कि क्वेश्चन बनता नहीं है इतने डिटेल में और इतना एलिब्रेट करके. तो मेरा ख्याल है कि अगर कोई एक क्वेश्चन, मैडम आपका साइक्लोस्पोरिन पे बहुत अच्छा आपने और डॉक्टर फारिया ने स्टडी की थी, तो वो उस ज़माने में ऐसी थी जिस तरह बायोलॉजिक्स हैं, तो उसमें आप कोई कमेंट्स देना चाहेंगे कि आप क्या कहती हैं कि पीडियाट्रिक पॉपुलेशन में आप क्या?
मेरा तो बहुत ही अच्छा एक्सपीरियंस है, और ख़ास तौर पर अब देखिए जब आप मीथोट्रेक्सेट से कंपेयर करते थे तो मीथोट्रेक्सेट स्लो बिल्डअप इफेक्ट आता था, लेकिन साइक्लोस्पोरिन का बड़ा अच्छा क्विक रिस्पॉन्स आता था. तो मैंने तो उधर हर जगह इस्तेमाल किया था, जिस तरह यंग आते थे लड़के लड़कियां, शादी होने वाली है इस किस्म का, एंड दे वर वेरी एप्रीहेंसिव ना, या जिसने कोई जाना है करना है. अभी भी इवन मैंने चिल्ड्रन में भी इस्तेमाल किया है, वेरी गुड रिजल्ट्स. और दूसरी एक ये चीज़ है जिस तरह डॉक्टर तारिक ने भी कहा कि जो इम्पॉर्टेंट चीज़ है बोथ इन सोराइसिस एंड एक्जिमा, कि जो इसकी ट्रीटमेंट में इट इज़ अ स्लो टेपरिंग ऑफ द ट्रीटमेंट. कोई भी चीज़ अब लगाओगे और उसको फिर लगा के ठीक होती है. नॉर्मली पॉपुलेशन क्या करती है, लगाती है ठीक होती है छोड़ देती है, तो रिबाउंड फिनोमेना बार बार आता है. सेकेंड, ये जो प्रोएक्टिव अप्रोच, मैंने अब I don't want to boast, लेकिन एटोपिक डर्मेटाइटिस, वेरी सीवियर फॉर्म्स ऑफ एटोपिक डर्मेटाइटिस, अगेन उनको अप्रोप्रिएटली करें, ये प्रोएक्टिव अप्रोच से करें, तो वो और साथ वो आपके साथ चलते रहे. इट में टेक मंथ्स, इट में टेक अ कपल ऑफ ईयर्स, आहिस्ता आहिस्ता वो उनका बिल्कुल ठीक हो जाता है. प्रोएक्टिव अप्रोच ही रहती है. साइक्लोस्पोरिन वेरी गुड हमारा तो रिस्पॉन्स.
थैंक यू सर. आपका क्या ख्याल है? आप यू आर प्रो टू मीथोट्रेक्सेट मेरा ख्याल है, तो आप उसके बारे में अपना क्या
ख्याल है? कि जो तारिक ने बताया है, ये सबसे बड़ी बात है कि जो ये नई प्रोडक्ट्स और ये नई हमारी टॉपिकल और ओरल ड्रग्स अवेलेबल हैं मार्केट में, और इतने मुश्किल नामों के साथ जो बोले भी नहीं जाते और जो मार्केट में आ रहे हैं, सिर्फ एक चीज़ हमने देखनी है कि इसकी कॉस्ट इफेक्टिव कितनी है और हमारी पॉकेट जो है, क्योंकि हर शख्स जो आपके पास आता है आपको सबसे पहले जो देखना है, मेथोट्रेक्सेट हो गया, साइक्लोस्पोरिन जो हम यूज़ करते रहे पहले, और इनकी अगर आप प्राइस देखें और जो आजकल बायोलॉजिक्स हैं और आजकल जैक इनहिबिटर्स हैं, हम ऑब्वियसली प्रिस्क्राइब तो करते हैं, लेकिन क्या हम ये देखते हैं कि हमारी जो मिडिल और लोअर क्लास फैमिलीज हैं वो इनको अफोर्ड कर लेंगी? फिर हमने इसका बैलेंसिंग करना है, क्योंकि हर शख्स को, इवन ये मार्केट में अवेलेबल भी हों, लेट से आपके डोर स्टेप पे भी हों, लेकिन आप हर शख्स को ये नहीं दे सकते। फिर ऑब्वियसली इन सब के जो साइड इफ़ेक्ट्स और कॉम्प्लिकेशन हैं, और बच्चों में स्पेशली तारिक ने बड़ा अच्छा जिस तरह बताया कि वी हैव टू बी वेरी केयरफुल जब बच्चे को ट्रीट करते हैं। तो अगर, तो मैं ये समझता हूँ विद माई एक्सपीरियंस जो किया है कि ओरल को पहले हमें नहीं करना चाहिए बच्चे में कहीं भी। आप टॉपिकल करें, और टॉपिकल के साथ जो भी टॉपिकल आपके पास ऑप्शन अवेलेबल हैं उनको यूज़ करें। और अगर उसमें आप समझते हैं कि एक पेशेंट जो है वो उसको उतना रिलीफ नहीं मिल रहा, देन ओनली यू शुड ऐड सिस्टेमिक ड्रग्स। अदरवाइज अगर बच्चा छोटा है तो उसमें ओरल के साथ हो जाए तो मैं कहता हूँ नथिंग बियॉन्ड इट। थैंक यू।
थैंक यू सर। तो टेक होम मैसेज दो निकले ना, कि एक तो लॉन्ग टर्म प्रोएक्टिव मैनेजमेंट और सेफ्टी ऑफ द ड्रग्स, और लॉन्ग टर्म कॉस्ट ऑफ द ड्रग। क्योंकि ये सारी अभी तक जो हमने डिजीज़ डिस्कस की हैं, एटॉपिक डर्मेटाइटिस, सोराइसिस, इन सब की लॉन्ग टर्म जो मैनेजमेंट है, तो उसके लिए आपने हमेशा पेशेंट की सोशो इकोनॉमिक स्टेटस का ख्याल रखना।